time frame for reporting abuse?
2 hours.
2 hours
2
for
hours.
abuse. And abuse is, someone give me an example of abuse. Verbal, physical.
Somebody hitting somebody.
Somebody hitting somebody. Other things that need to be reported to the state is if there's neglect, some kind of maltreatment, mistreatment, or financial exploitation, a patient elopement. Anytime a resident gets outside of our building and we lose sight, if they go to the door and they push and they got their foot halfway out the door and we're able to bring them back in before they get far, that's an incident report, but we don't have to report that to the state. But if we have a situation where somebody gets outside and they're outside for minutes and we don't realize that they're outside, we have to report that to the state. Significant injuries have to be reported to the state. Anything that's suspicious looking, like if a patient falls and we have to do it and they have to get an x-ray, or if they have to go to the hospital after a fall, that has to be reported to the state. Even if they go to the emergency room and it turns out that they're fine and they come back later, if it warrants them getting sent out, it has to be reported. Any med error that, like if it's just a mistake, like hey, I accidentally gave them Tylenol at the wrong time or something, that's not reported. But if it's something where you have to monitor them or they have to go to the hospital because they got the wrong medication or whatever, that has to be reported. If a resident spills their coffee and they get a greater than a 1st degree burn, like say they spilled their coffee in their lap and then when we took them to the bathroom we noticed there's a blister, that's a 2nd degree burn, that would have to be reported. And there's an 8-hour time frame for that. Any kind of bruises that we see that are unknown origin, that are not in vulnerable areas, have to be reported to the state. So face, if people have bruises like on their chest or genital area, those are suspicious areas, so those have to be reported. Suicide, poisoning, fires, if we run out of electricity for more than 8 hours, if we have a flood in our building or some kind of ceiling falls in or something, those are reportable incidents. Anybody have questions on reportable incidents? Okay, I'll keep it rolling then. My other part of the in-service I wanted to talk about, our in-house pressure wounds are at a very high rate right now. We have several skin issues throughout the building, and I want to address that we've got to work to get our pressure sores down. Some of our residents are on hospice, and so when they're on hospice, it's a little, I'm not as concerned as that, because we expect a decline. We expect the residents to stop eating and things like that, and when they don't have the nutrition that's expected. But we do have a few wounds that are happening on people that are not necessarily on hospice. The kind of wounds that we're seeing, a lot of people are getting them like on their sacral area and coccyx. We have a few people with those kinds of wounds, and we're finding a lot of incidents of heel wounds. So I just want to bring that to everybody's attention. We need to be very aware of like some of the risk factors for skin breakdown. Does anybody know what puts somebody at a high risk for skin breakdown? Diabetes, malnutrition. So if you notice that some of your residents aren't eating well and they're not moving around in the bed, or they want to lay in bed a lot, if they're having more incontinence is also a high risk factor for skin breakdown. We need to stay on top of those things. I'd rather us be proactive than reactive. Everybody should be getting barrier creams. Nurses, we need to make sure that we're doing our skin checks, because it looks really bad when we pull up the assessments and we see that skin checks are like a week behind And then when we do a skin check, we find out that somebody they have a sore that looks bad, it looks bad on us. So we are gonna do that. A couple things that, just so you know, some things that we wanna do is, obviously we wanna make everybody aware today of our game plan. But we do have a wound care nurse available. We did not have one available very regularly to us. We do have one now. So we are going to be having wound care come in and follow some of our wounds. And if you feel that somebody needs to be seen by wound care, please, nurses, CNAs, let me know, because we can get them on the list. They'll look at rashes, they'll look at, you know, if somebody's just got a red bottom and we've been putting stuff on it and it's not getting better, we can do that. We want to make sure we're staying on track. One of the things that I'm committed myself to do is making sure that the wounds are getting measured weekly. Also, we want to make sure that skin checks are getting done on admissions as well. So usually, I know we're a little bit different, not legislative-wise, but state-wise, we're a little bit different, but other facilities I work, if you don't notice something on a skin check and it's past 24 hours, it's yours. So like if somebody had a sore and a skin check wasn't done and that resident has been here for more than 24 hours, it's technically it's an in-house sore because it wasn't noticed on the admission. So we need to work together to make sure that those kind of things are being done on time. We need to hold each other accountable for making sure that showers, hygiene, turning, repositioning, making sure that residents have their heels offloaded, because that's a big issue with the heel wounds. Right now I got, I think there's been 4 or 5 heel wounds in like the last few months, and it shouldn't. We got to stay on top of that. I also want to work with our wound nurse when she does come in to see if sometime in the near future we can do a facility skin sweep on everybody. So some of the other things when it comes to skin, I just want to make sure that nurses, that the weekly skin checks are being done on that. Make sure that there needs to be communication between the nurses and the CNAs. I feel like just make sure like that if you need to do a skin check on somebody, that you get with the CNA and say, hey, so and so's a skin check. Make sure you call me. I'll be here. Let me know. You know, and I know that happens a lot and people are doing it, but I want the skin checks to be done regardless if the resident's like, I'm not showering tonight, I'm not going to do it, and the CNA ends up doing a bed bath, I still want to see that the skin check is done. If the resident is not wanting to do a skin check, if the resident doesn't want a bed bath and won't let anybody do anything, I still want the nurse to go in and try to get the skin check done. And if it doesn't happen and the resident is like adamant, like, no, I'm not gonna let you do it, write that on the skin check. The resident wouldn't let me do it. So that way the skin check gets closed out, and write a note to document. If a resident refuses a shower, there should be a nurse's note. If a resident refuses shampoo, if they don't let us do hygiene, so that way when families come in and somebody doesn't smell right or look right, that we can go back in the documentation and we can see, like, yeah, it's not that we're just not doing them, that they're refusing. Also, for the nurses, I would like, when we use zinc barrier cream as a skin, as barrier cream when people are incontinent, but we also use it from time to time when people are starting to break down. So if you see a little red area, superficial area, and you're putting zinc barrier cream on it, I would like that to go on the MAR or the TAR of the patient, so the nurses are signing off of it. So nurses, when you see, for example, we got a new resident the other day and they're getting they're getting some zinc oxide on a place on their back that they came in with. It's on the TAR for the nurses to sign out. So nurses, when you see things like barrier cream and things like that on the treatment record, that means that somebody has an area of concern. And that's why it's on the treatment record, so that we're following it, so the nurses know, like, there's an area of concern in that area. That being said, with things like barrier cream and Comaceptine and A&D ointment and Venelex and all that stuff, I am totally fine with the CNAs putting that stuff on. But I just want to tell the nurses, if it's on the TAR, my expectation is that the nurse communicates that to the CNA, so-and-so is supposed to get zinc to their bottom, and that it's communicated, that the CNA knows that that's what it's for and where it goes. I don't just assume that just because there's a tube of cream on somebody's sink, that the CNA automatically knows what they're getting and where. So take it upon yourself. What I don't want to see happen is someone's supposed to have zinc on their bottom, and I go to the CNA and ask about it, and they tell me, oh, they've been without for 4 days, or we've never had zinc, or whatever, and then the nurses are signing off that the person's getting it, and so that's what I don't want to see. Zinc, Shonda has we have tons of zinc, and it's up, and just ask Shonda. Shonda's got tons, we've got tons of it.
It's not in the closet, it's at my
It's not in
desk.
the closet, just I have to ask for it, but we do have it. So, just don't assume. And also, we just need to make sure that we're holding each other accountable, that residents are getting turned and repositioned. Like, you know, we need to check, we need to hold each other. When we see that somebody's been in the same position for 3 or 4 hours, we see somebody slumped over in a wheelchair that's been sitting there for 3 or 4 hours, we need to communicate and get people into position. Any questions so far? All right. And also,
what did you say about the zinc? Did you say it's not in the supply room?
it's not in the supply room. So if you need zinc, just ask Aunt Shonda for it. We've got tons of it. We have tons. Yep, ask LaShonda for it. Yep. And also, for the nurses, in your documentation, make sure if you see an open area, if somebody has a blister or don't just write in the notes, so-and-so's got a blister, what did we do about it? You know, just saying that they have a superficial open area on the left buttock doesn't really, especially if it's on like a weekend or a Friday night and somebody's writing that down. How is if the next shift doesn't read the 24-hour report, how are they gonna know that somebody has an open area on their bottom? And what happens is days go by and next thing you know, it's not just a superficial open area, it's a full out sore. So there has to be communication. When you see somebody that has an open area, we need to document, we need to put something in place. Put it on the MAR, put it on the TAR. Make sure you write a note, put it in the doctor's book, cover yourself, let the doctor know, put it in the doctor's book. And that way there's communication. That's how I know. I read the 24-hour report. When I see things, I go through people's orders, and that when you see like, hey, they're supposed to get zinc to their bottom, something must be going on. For the CNAs, make sure that efforts with the shower, make sure that showers make an effort to make sure they're being done. If there's a refusal or an issue, you notify the nurse. Everybody here, all the patients that are incontinent should have some type of barrier cream. If it's A&D, zinc, Comaceptine, something, like we need to be proactive. So if they're incontinent, you have to change them. We should have putting on there. Not that we've seen an issue, but I just want to make sure everybody knows that there is no double briefing. Double briefing, what happens with the briefs is that you cannot, first of all, it impedes the amount of oxygen that they're getting to their skin. It holds in, when you put 2 briefs on, it holds in more moisture, it holds in heat. It's bulky, and they're sitting on top of that bulk. So that bulk just makes the skin break down even more. And we've got too much skin breakdown, so there's no double briefing. There's no, like, even if you cut a pull-up and make a pad out of it and stick it in another pull-up, in my mind, that's the same as double briefing. So I just wanna let you know that's no double briefing.
The
Make sure.
pads, the pads was a practice that we accepted before. It is no longer accepted here. We don't do the
And I
pads.
haven't been seeing any pads around in a while,
We're not doing it.
at all. So just wanna also let you know that, make sure that your residents have their heels up. If you need pillows, we got pillows. We can use, you know, rolled up anything to keep the heels from rubbing on the mattresses. The low air loss mattresses, the air mattresses, right now we got 3 people on air mattresses. And one of the things that we need to know about air mattresses, the more things that you pile on top of that mattress, the less effective the mattresses are. So when you have a fitted sheet and you have a quilted pad and you have 2 quilted pads and you have a draw sheet, it's no different than laying on a regular mattress. It totally defeats the purpose. I would like for us to get in the practice of less stuff under the people that are, right now, the people we have the people that we have on air mattresses right now is East Hallway 101, and there's somebody on the old side in 128 that has an air mattress. So for that, they need a fitted sheet and really just a draw, like a sheet folded in half as a draw sheet, and that just enough. Those quilted pads hold in the heat and the moisture, and they totally defeat the purpose of the air mattress. What I'm hoping that we can at least get some of these guys that with the skin breakdown, I'm hoping that we can get them moving in the right direction. So, everybody should have a cushion for their wheelchair. If there's in the closets, we have extra. Everybody should have a cushion. If they don't have a cushion, we can find a cushion. We have extras everywhere. But it's the same, the thing with the cushion, it's the same principle as the air mattress. The more padding and incontinent, you know, we've been putting the, what do you call it, the quilted, I don't know, pads underneath of them to keep the cushions dry, but the more stuff we add to it, the less effective it is. So I would like to just see residents sitting on the cushion and not having them sitting on a pad. And then when we add, I know we have a lot of fall people, and we add the plastic pressure pad to it, we're just adding more, so it defeats the purpose. So try to have them sitting on less. Any questions? Any questions about the skin? Okay, next thing we're gonna move on to is behaviors. And I wanna just clear up some misunderstandings, because I feel like people feel like we're not allowed to medicate people for that. And I want to let you know that I and our practitioners and other people, we're not opposed giving medications to our residents when it is appropriate. But we just have to understand that a lot of the medications that are used for agitation and things like that have side effects that are harmful for elderly people. So a lot of times on some of the medications that you use to medicate people make them at higher risk for falls. There's a high percentage of our residents that take antipsychotic medications. They have to have additional assessments. They have to have an AIMS assessment every 6 months. There has to be behavior monitoring in place. And they also have to have routine lab work, because these medications are hard on the liver and they're hard on the kidneys. And so there's other addition monitoring. So when I get asked, like, can't we just give them something? I just also want people to understand that on the back end, there's more to it than just giving somebody a pill. I know it's been difficult, and I know right now we've got, especially on the North Hallway, we have a lot of behaviors, we have a lot of sleeplessness, we have people up all night and being combative, and look, I appreciate people just willing to give good care to our residents. wanna let you know that, we did, for one of our residents, put some behavior modification things in place for them. Our goal, what I'm really wanting to see especially, is that we're establishing a bedtime routine for our residents, and that we're encouraging, and each shift kind of plays a role in setting up the next shift for success. So I just want, we can't, we want our residents to sleep all night. So we can't, I know it's kind of, we get busy during the day too, and it's kind of convenient, hey, they're dozing right now. Okay, it gives us a chance to get work done. But we can't let some of our residents take long, 3-4 hour naps during the day. We need to make sure we're waking them, not letting them sleep through meals, because our goal is that we want them tired out so they'll sleep at night. Also too, I've spoken to some people in the night shift. We have just a crowd sitting at the nurses station that aren't sleeping at night. They're sleeping in recliners, and we are trying to work to get these residents to try to, at least for a little while, lay in bed. We have purchased a few pressure relief, pressure pads that go on the bedside, that when they put their feet on it, it'll alarm, because I know we have some people that are able to turn off the other alarms, and they're able to, get around that. So we are trying to encourage people to sleep. I just want to remind everybody, if there, there's also I have food in my office, there's snacks in there. If residents are up, if they're agitated, if you need something to calm them down, or you want them to sit for a few minutes, I am fine. You don't have to ask my permission, just go in, get what you want. I keep it on it's right up there with the juice and the prune juice and all that stuff. Just take what you need for your residents, no questions asked, just get what you want for them. Make sure that we gotta remember that they're not they're not acting out on purpose. And remember that a lot of them, they don't remember the conversation that you might have had a great day with them yesterday, and they sat for you and they didn't try to get out of the chair, but they're not gonna remember, if they have dementia, they're not gonna remember yesterday. Right. They're not gonna remember the conversation you had an hour ago, and they're not gonna remember 20 minutes ago. So we have to remember that, we have to remind, they forget, they don't remember that, hey, I fell 2 months ago and hurt my leg. They don't remember in their mind, they're used to walking their whole life without a walker. I don't remember that I need a walker. So we have to remember those things. A lot of our residents that we're dealing right with now have aphasia. They don't understand, in addition to being hard of hearing, some of them, they don't understand what we're saying. So speak loud without shouting, and clear, and try to use as few words as possible. And so one of our gentlemen in 116 has aphasia. I find the more words I use, the less likely it's going to be that he's going to listen to me. Try to keep it 2 or 3. Sit down and leave it at that. Or, point to the toilet. Show them the toilet. Try to do it. We're just trying to find strategies to help. But just remember that, they don't. Sorry. That's fine. They don't always understand. We might have to repeat ourselves multiple times before it finally sinks in what they want us to do. And we need to be aware of our own body language and our tone of voices. I know, sometimes we mean well. We want to keep our residents safe. We don't want to see them falling in the common area. But we have to realize when we shout, hey, sit down, sometimes I don't think we realize how that sounds, you know what I mean? And it comes across to our residents, and they get frustrated because I'm a grown person. Why are you shouting at me, telling me to sit down? And they get frustrated. So we need to do that. And also, especially with our aggressive residents, avoid touching them until you get some kind of signal from them that it's okay to do so. When I know, we see residents trying to push other people in wheelchairs, or they're trying to go in somebody else's room, and my knee-jerk reaction is to grab them by the arm and no, don't go in there. But when they're agitated and I'm touching them, they don't see me coming, they don't know I'm behind them, and I'm laying a hand on them, I might not get a good reaction from them. They might elbow me or punch me because they don't know what I'm trying to do. They just see me grabbing at them. So try to make eye contact with the residents and get some kind of recognition from them before you have to put your hands on them. So that way they don't get hit. So, and we also have to consider our unmet needs, because residents have, what are some unmet needs that our residents might have that might make them more agitated? Anybody know?
Hot, cold.
If they're hot, we're hot in here. So when someone's in the hallway and they start taking their clothes off, that might be a reason. They might be hot. So that might contribute to some of our behaviors. Being thirsty. A lot of the medications that these guys are on, especially the psych medications, make you thirsty. So give them water, give them juice. Being hungry, they don't eat all the time, and some of them forgot that they ate, and they legitimately feel hungry, even though we saw them eat and they ate a whole plate, but they forgot. Give them something to eat. Having to use the toilet. I'm sorry, but this one really gets me too, but constipation is a real thing that makes people agitated. A lot of the medications, just about every medication, I feel like people could take, a side effect is constipation. And I know, because I've worked in long-term care forever, the law of the land is like if they go 3 days without having a bowel movement, then they're constipated and we give them something. I'm saying, and I think all of us can agree, that 3 days is a long time to go without moving your bowels. And if you go and you take your residents to the bathroom and they're just passing little pellets, I'm sorry, they're constipated and they're probably miserable. And that can also make them more agitated and fighting, because they can't, a lot of them aren't going to be able to tell you that they're constipated, but you see it. So if you're toileting people and you see that they're not having much success in the bathroom, let us know so we can get them on something to make it easier for them. Any questions? All right, we're getting now near the end here.
So Janelle, what happens, like, you know how sometimes for one of my residents, he gets agitated when you're like, hey, stop, or like if he's about to fall, do I break his fall or do I let him fall? Because they, like, when you go to be like, oh my God, you know, if they're about to fall, like, they don't want you touching them and helping them. Do I let them fall on the ground, or?
No, I mean, obviously, we're not telling you to let somebody fall.
Yeah.
But
in
if
the
they
case
don't
of a
want
fall,
you touching them, like,
yeah.
if you're like, stop, no.
Yeah.
You see them like about to trip over their walker or something.
In the
Do
case of
you
a
stop
fall,
it?
I feel is different. I'm talking more of like, we're trying to redirect them away from something, you know what I mean? Like,
falls fall under the urgent category.
Yeah,
Because
That's
one of my residents today, he couldn't get by, and it really was no room to move, and he literally picked up his walker, and I'm like, hey, and he's like, and I'm like, okay, well, do whatever you want to do.
we recognize there's some
Yeah.
like situations where there's no
So like,
good
if he was to
situation.
fall, and I'm like, you know, do what you want to do. Is that on me?
No, don't just let him fall.
Touch
Do not,
him?
do not just let your resident fall.
but
You
you're
cannot.
trying, but you're trying to caution, you're not gonna be like, well, I'm just gonna let him walk around with his walker up like this. But you're
Well, that's
trying,
what I did, let him
but you're
do
trying
it.
to you are trying to intervene, and you're trying to tell them like, that's not safe, don't do that, you know what I mean? Like, you know, like we're not just gonna turn a blind eye to that, but we are gonna try to do that. But it is hard, like, it's, cause some of our residents,
I'm gonna do 3 minutes when you're done.
oh yeah, sure. And so the last thing is resident safety, and I just wanna say, with the care plans on the residents for like transferring them, like Hoyer lift, sit to stand, 2 people, 1 people, I realize that we have consistent staffing, and so some of you that have the same residents over and over again, you speak their language and you're able to get them to do things that the other staff, when they only have them once in a while, or I've never had this patient and they can't do it. So sometimes you're gonna find that some people I have to do what's safest for the resident. So if you see a resident and it says sit to stand, and you know, like for me, like that resident can transfer, I still have to make that resident a sit to stand, because what will happen is when you're off, they're gonna look at that plan of care and they're saying, oh, like he's a one person, and boom, like, oh my goodness, like I didn't know, like this was so hard to transfer this person. So I just asking that when we pay attention to what's on the care plan, because if we have a fall and we're not following the plan of care, what's in the CNA documentation is what's in the person's care plan.
Can we go back through all of them?
Huh?
Can we go back through all of them?
If you have questions about them,
Cause like, Norman wanted to go fishing. Like my resident wanted to go fishing, he was like, in the assistant stand. I said, no, we go up all the time with 2 people in the assistant
Yeah.
stand. Then we make it lighter, but everybody
Yeah.
kind of says, no, you can't use them, we're gonna.
Yeah. I have to evaluate, like again, like I'll have to evaluate on an I'll have to evaluate on an individual basis. But what happens is I have to also make it like when the regular staff isn't there, if it's a weekend and people are off or on vacation, I wanna make sure that the resident is able to be transferred safely. And so if you, cause I realize that like CNAs get, like the CNA resident relationship is amazing. Like when you have the same residents over and over again, you can do magical things with them that other people can't do. But I also have to set the other people up for success that don't always have that resident. And so if they're looking and like, hey, Debbie can do this by herself, I can't, you know what I mean? And they go and try and then like the resident falls out, I have to make it, safe for them. So that's what I'm saying. But I'm also willing to look at things. That being said, things change and we can update things as, people will get stronger, people get weaker, and that's the nice thing about a care plan. They're continuing and we can change them. Just a couple other things about safety. You'll notice the Hoyer lift crossbars have been padded. It's like a tan, brownish, leathery looking. Please do not remove those. Those are an intervention from an incident that we had, a bruise of unknown origin. So please do not remove those. Please do not, if you see any pool noodles on bed frames and things like that, do not take them off. They're part of the residents' care plans. Just kind of safety, we have a lot of beds that have the missing, caps on the ends. We've had some people get skin tears from that, so a lot of those are being covered up with pool noodles. We have people that fight and, they hit at staff, and we have their side rails padded so that way they don't cut their skin, get skin tears. So just be aware that stuff's there. If it comes off, let me know, I can cut it again. And the last thing, and then I'll give Tim, and then we'll be done. The last thing too is, we've had a lot of bruising, our falls have been down the last few months, but our amount of bruises have just skyrocketed. And there's been quite a few that were reportable to the state. Just unknown, weird places, unknown injury that we've had to investigate. We did find that one was from that Hoyer swings so much, that's why they're padded now. But if you are taking care of somebody and I don't want you to feel like you're gonna get in trouble, but if you take care of somebody and say I was given incontinence care and the resident got combative and went to punch me and I dodged the punch and they punched their side rail and you looked at their hand and there was nothing on it, let the nurses know, let me know so that we can make a note in their chart. So when 3 days later comes around and their hand is all swollen and bruised, we know where that bruise came from.
Right.
If you, if a resident, you were pushing a resident and they accidentally their hand was hanging down, it got too close to the wall and they, kind of hit the wall with their elbow or whatever, let us know so that way we can just look. Bruises don't always show up right away, so at least we know, we'll have an idea of where things happen. It's I would rather people just be straight up, because what happens is the bruise doesn't show up for days later, and then we find it, and then we have to ask people questions, and then nobody ever remembers. Well, I don't know, it wasn't there, haven't seen it, don't know anything. So just report those kind of things. Thank you.
Okay, I'm gonna try to be really quick, so I hope you guys can just focus in real quick. I'm trying for 3 minutes, so you guys can yell at me if I get past 3 minutes, okay?
I'm
So
turning
I
it
just
on.
have, I have 4 things, but the first thing I had was kind of on that with the reporting and accountability thing. I really believe all of you should know by now, we are the type of people who are for you, not against you, right? So we're not the type of place that is trying to it's not that we just want to get people in trouble, right? So that whole thing of accountability, we believe is actually reporting these things actually has more to do with protecting yourself than getting in trouble. You're more likely part of the thing is our reputation is known right now. When people come here, because of the reputation of so many of you for so many years, that reputation is such that when we give a tour, when we bring somebody in, there's a good reputation. People actually come in thinking, I can trust these people. We want to keep it that way. A lot of other facilities, the state reports that happen on them from upset families saying, reporting them to the state. We don't want that. We want to be people of accountability and taking ownership. And so that's just what I would have to say about the reporting. Teamwork. Teamwork makes the dream work, right? We all know this. It's a lot easier said than done. But I was thinking about this recently is people we care about, often we still hurt, right? We still have this, even in families, parents, kids, siblings, that's where a lot of times hurt happens. But at the end of the day, we say family matters. And it matters so much that it's worth the pain and the struggle. And I just want to encourage you guys, I understand we're not all blood family, but we are a family here, and we should care for one another. It should be worth pushing through hard because it matters. So I just want to encourage you guys, we care about you, we want this, we want each other's good. I forgot, I should have said this earlier. One of the focus points on last meeting was linen. Do you guys think we've gotten better, stayed the same, or worse?
Some days good, some days not.
Yeah, so we gotta go for the whole time. In the last 6 months, I would say it's at least just as bad. So we have, not done so bad, 12 dozen bibs. In 6 months, 12 dozen bibs we've had to order. 10 dozen hand towels. How many dozen washcloths do you think we have had to order? How many dozen? Anybody thought a number? 24? Anybody else got a number? 30. 200.
What?
200 dozen hand towels. The washcloths. Please, again, if we're gonna keep talking about this every single time, please help me. Everybody hear me. This is a mandatory meeting. So all my nursing staff understand. You do not throw away washcloths. Let the laundry decide on that. Again, if you see a resident that is chunking it or something or pack, please step in. I'm getting. Look at me. All right. This is my final thing. Talking about how we love you, how we appreciate you. Mark your calendars. August 21st. We are having our annual crab feast cookout. You are invited. You are invited. Tanya, will there be shrimp there?
Yes, it will.
There will be. There will be shrimp there. There will be what else? Come on, Debbie, what else? What do I make every year? Brisket. So if you like you some brisket and you like you some shrimp and crabs, please be there August 21st. We are allowing a +1. Okay?
No exception.
One +1. Todd, what'd you say?
No exception.
No exception, just one.
Where's it
I
at?
can only bring Diana. The places to be determined. We've been doing it here. I'm really thinking very seriously of doing it at the Red Barn. If you guys have strong opinions, tell me. I'm really thinking strongly about doing it at the Red Barn, and we're gonna do it from 1 o'clock on the 21st, 1 o'clock until like 3:30. So if you come in early for your shift, you can come and then leave. If you finish out your shift, you're still gonna have plenty of time from 2 to 3:30 or whatever. So, and then for those that, like the nurses, I know that your schedule is just a little awkward for that. We'll try to make it work, but I'm leaning towards the Red Barn because it's just a nicer venue. Any questions?
I'll get most of the shrimp, y'all.
You couldn't eat all the shrimp I'm gonna be having. Thank you, Janelle. We are always here. Please talk to us. Okay?
And I'll just, so that way we can get out, I'm trying not to keep
Do an
it long.
introduction for the camera because they'll wanna.
Okay,
I'm gonna zoom in on you.
this is the mandatory nurse and CNA meeting, July 22nd. Thank you. So today, one of the couple things that we're gonna be talking about, these are some things that we've been having some issues with as of lately. So I wanted to review with all of you what type of incidences we need to report to the state, because it's very important if something happens in our building that those things get reported timely.